Hello, I would like to welcome you to our January 21st TMIT Global Research Testbed High Performer webinar today. We have a terrific topic and a fantastic speaker. The topic is an ultrasound revolution, the impact on emergency care. I'm Charles Denham. I am chairman of TMIT, and I'll be the master of ceremonies and coordinator today for our discussion. I'd like to just remind everyone that's watching this program in terms of enduring content in the future, you may go back to safetyleaders.org and be able to access the webinar page and download and look at updated information and be able to watch the full program there. For those that are watching live, if you don't have the slides, please go to the upper right quadrant of the landing page and click on where Dr. Chris Fox image is, and that will take you to where you can download the slides. We have nothing to disclose, and I've highlighted because we're so careful about disclosure. None of our speakers today have anything to disclose, and Dr. Fox will be showing some ultrasound equipment, which he has to, although he has had no direct, indirect, or affiliated compensation from healthcare device or industry for more than 5 years, and none of us have as well. However, we have to show technologies today to be able to have him share his talk on ultrasound. If you wish to go to our social media accounts, you'll find those on the page after disclosures. And I'd just like to go over our purpose, mission, and values for those of you that are new to us. Our purpose is that we will measure our success by how we enrich the lives of families, patients, and caregivers. Our mission is to accelerate the performance of solutions that save lives, save money, and create value in the communities we serve. And our core values are spell I care, integrity, compassion, accountability, reliability, and entrepreneurship. And we try to live and breathe those values. Just so you know, the network that you are accessing today is a network of over 3,100 hospitals and 3,000 communities, and a subject matter expert pool of about 500 subject matter experts that have developed organically over the last 35 years, but really grew rapidly through our work with the Leapfrog Group, the National Quality Forum, the Premier the GPO and the VHA GPO over the years. Now we have this terrific pool of subject matter experts and a network of about 85,000. Not everybody attends every one of our webinars, but those of you that are fresh, that's who you're joining with us. We always start a program with the voice of the patient. Arlene Salamandra is going to start us off with an inspirational statement and just remind us our compass heading today and our focus is on patients and their families. Arlene is a published author in patient safety. She's spoken on a number of national groups. Most noteworthy is that she was part of our core team that worked on the hospital-acquired conditions, the HACs, that are being measured now at the end of the first decade. However, billions of dollars have been saved and hundreds of thousands of lives have been saved due to the 11 hospital-acquired conditions. And she was part of the grassroots team that we worked with and led to be able to help get those across the goal line. So Arlene, thank you. And thank you, Arlene, for being one of our resident experts in power gradients, bullying, and what can happen to our caregivers on the job with patient safety. So thank you, Arlene, for starting us off today.
Hey, thank you, Chuck. And I want to thank you for always, every webinar, we have a patient voice. And I think that's so important, not only to hear from our perspective, but things that we could also teach our family by listening to the webinar. So I really appreciate the presenter here being here today, and I'm looking forward what I could learn and carry on to other patients. Thank you.
Thanks, Arlene, and thanks for being such a steadfast supporter. 154 months in a row we've been doing this, and you've been one of our leading patient safety advocates. So we won't say how old we all are. Today, I'll just do a quick highlight on our coronavirus care community of practice. Dr. Chris Fox, who's the chair of the University of California, Irvine, is one of our wonderful experts that's helped contributed to it. However, he'll cover today ultrasound, but I want to thank you, Chris, for being a terrific contributor to us in emergency medicine, as well as Arlene. Very quickly, we are hopefully we are peaking in terms of the number of infections and deaths. We don't know, but we have infections now. We're counting every second and deaths every minute. And if we look at the numbers that have just been updated in the last week by one of the major modelers at the University of Washington, which the government is using, we've just seen this incredibly steep curve of infections, hospitalizations, and deaths. And we know that Dr. Fox is taking care of a number of such patients here in Orange County, California. So IHME is this modeler, and this is what they're projecting in terms of deaths out into May. So we know we've got a significant problem. I just want to draw your attention to, and those of you that are new to us, I always try to cover something that's newsworthy, that's real time. Wall Street Journal came out with an article that described the new variants and how the new variants of the virus attack the cells. And so I recommend that you read it. Very short article, but it's done a nice job at describing the new variants. And because of these new mutations, two things are really going on. One of them is the D614G variant, which is now the dominant variant across the country, has had an opening of the spine proteins on the virus, which actually has made it more transmissible. And that's why it became more transmissible than the one out of Hunan, China. This is the one that came through Italy. And the second part of the article, which is interesting, addresses the three variants that have popped up. The variant in the UK, which is called B1 or B1117, and the P1 variant from Brazil, and then the B351 variant from South Africa. And there are two different components. One thing is that there are changes in the receptor binding domain where they attach to the cells that can make them more transmissible. And the second component is in what's called the N-terminal domain, where there are missing elements in the UK and the South African variant that may make it more elusive to our immune systems. And so these are two factors we'll have to keep our eyes on. When the coronavirus hit in New York City, we assembled a 70-member team that's now grown to 90 subject matter experts, including those that contributed to our 2 Discovery Channel films and are contributing to our third, which is called 3 Minutes and Counting. We started a program that UCI, where Dr. Fox is one of our wonderful contributors and partners, called MedTech, and that's where the coronavirus program developed. And we began to focus on family transmission chains in these 16 industry sectors on the right declared by Homeland Security. What we did was we said, what can we do that maybe no one else is doing, where we won't compete with anyone, but maybe we can add value? And it was to focus on the family transmission of these sectors that keep the lights, the power, the water, care for us, protect us, and keep IT and finances flowing. August 18th, educators at all levels were added to that group. So we started this community of practice, of which we have run many over the last 35 years, 4 for Google, a number for Siemens and GE, and a whole host of leaders, also Agency for Healthcare Quality, the Leapfrog Group, the National Quality Forum. And our method is to convene, connect, celebrate, co-create, and have impact changing the world. And so what happened was this branched out of a bystander care program that we developed about 5 years ago here in California at MD Anderson and at Mayo Clinic. And we have a number of articles we won't refer to today so we can get to Dr. Fox's presentation. But we just want to draw your attention to these. We've had, I think, 7 articles in Campus Safety Magazine, a number of medical articles. And basically the payoff here is we can't, the family unit, we believe, is the Achilles heel with this family transmission issue. We can keep people safe at work, and then unfortunately people are getting sick from those contacts they have in the community, especially when we have enormous community transmission and high infection rates in the community. So we believe if you save the families, you can save the worker. If you can save the families across communities, you can save the nation. And we didn't know we would be right, but it it turns out that the data is now very supportive of what our findings were, that was true. So we offer a number of we do 90-minute webinars the first Thursday of every month, and we do this 90-minute webinar the third Thursday of every month. But we produce basic short video modules, 4 to 10 minutes, you can watch on your phone, or you can watch the 90-minute programs, and we deliver CME and CEU credits. So this is my pitch for February, and this is right up Chris's alley. We've covered a number of topics, but February, the first week in February, we're going to be addressing the emergency rescue skills that families need to know. When should they take their family member to the hospital? What do they need to know about going to the emergency department, Chris? What do they need to know? What are skills that they really need to take care of family? Our first 90-minute program was coming home safe. How do we keep from bringing the virus home? Hot zone, warm zone, where we decontaminate, and then the safe zone, where we're at home, where we may have to take care of someone. So then we covered keeping our kids safe, and this was assessing our vulnerabilities in our community and our families' vulnerabilities that could really drive whether our kids go to school or not and what we do. And we covered a step-by-step approach there. So we recommend that you go back to watch those if you wish. Our third, we did how to put together a family safety plan, where we went through what we call the 5 R's, which are readiness, response, rescue, recovery, and resilience. We followed that with the following month, we actually provided checklists that you could have for your family, where we put together the kinds of checklists that you might want to have for your family. Or we have a number of college students on our team. How would you, with your roommates, put together a strategy? And then finally, how do you take care of someone at home? And we have infection preventionists that work very closely with us, doctors, nurses, infection preventionists, to tell you how to put together an isolation room at home. And then what are the checklists that you need to put together in order to keep the rest of the family safe and take care of someone at home. January, our first program of the year was then, how do we factor in vaccines and testing, and what do we do regarding our 2021 plan? Finally, we put together a program over the holidays, which now is all year round, which is how families can have gatherings and avoid what we call double bubble trouble. And this way we have been teaching kids, scouts, families on, if you are going to force yourself to have families get together, which the CDC does not recommend and we don't recommend, but if you were going to do it, how would you make that more safely, a safer experience? And then finally, this will be our webinar in the first week in February. So we've undertaken a study. We started back in March. We have over 750 family responses. We hear from WHO now that we're the world's largest study in family transmission, which is kind of neat, but kind of scary actually, that others haven't been working on this field. And so we want to have you all take the survey we did last month regarding our end of life efforts. So I'm going to ask Evelyn, who's running our webinar today, to put the survey up. And while Dr. Fox is speaking, perhaps you can follow, you just answer these 5 questions, because it will help us build our program. Readiness on a scale of 1 to 10, where you're very ready. And I'm going to move my poll out of the way. Where you feel very strongly that your family is ready, very strongly disagree would be a 1. And what we want you to do is just respond to our survey and help us make this a better program. Does your family know what to do if a loved one gets infected or sick, exposed or sick? Rescue is, do you know what to do if someone gets severe symptoms and needs emergency care with someone like Dr. Fox? Recovery is, your family has a safety plan to return to work and play when the coronavirus social restrictions are relaxed. And then the final question is resilience. Do you have a plan to learn from what's going on and make your family what we call hardening the target in anti-terrorism or active shooter events or insecurity? Do you have a plan to make yourself less vulnerable to that? So this has been a delight to work with Dr. Fox. We're now moving on to him. I think we're right on time here, at a minute ahead of time. Dr. Fox is a professor and chairman of the Emergency Medicine Department at the University of California, Irvine. He is an author of 100 peer-reviewed studies. He has been a sole editor of a number of books. He's been an enormous contributor to the body of science in use of ultrasound. And I think particularly important is his passion for education. He's been a leader, global leader in educating medical students, which you'll hear in his talk, and educating medical students and medical staff on the powerful use of ultrasound, which is just he gave us his presentation here a little earlier this week, and it's one that I look forward to more than any that I've thought about in the recent past. So I'm excited to have Dr. Fox take over. I'm going to stop sharing my screen, Dr. Fox, and then you can go ahead, and really look forward to your presentation.
Great, thank you so much. Can you hear me okay?
Great, here, 5 by 5.
Awesome. All right, well, thank you for that introduction, Chuck. Yeah, it's nice to learn everything that you're doing, and especially with regards to the update there on that COVID variant. I didn't know any of that, so that was fascinating to see that. It's such a rapidly changing thing. So we're going to change gears a little bit from COVID, and I mean, all I've been talking about every day has been COVID for the last, year or so, but it's nice to take a break and talk about something else. And but in my talk, you will hear me talk about how we use ultrasound in COVID as well. It's inescapable. So, in fact, my very first slide is a COVID patient. So, but I would like to just sort of frame this with ultrasound. When people think about ultrasound, I think the first thing that comes to mind is probably ultrasound in pregnancy, and ultrasound can be used across the entire body, as you're about to learn. And ultrasound machines themselves have become quite portable and a lot less expensive with the as Moore's law, as the processor speed doubles every 18 months. Ultrasound companies have certainly leveraged Moore's law and made the machines smaller and less expensive and more powerful. So as cell phones have become so powerful, so have ultrasound machines, and then the two have become married. So that's what's made this revolution so exciting. But I tracked on it really. I was lucky to track on it really early. About 20 years ago, I did a fellowship after training in emergency medicine. I then did a fellowship in ultrasound, and since then, I sort of drank the ultrasound Kool-Aid, if you will. And I've just been teaching it and writing about it and using it in my daily practice in our level 1 trauma center at UC Irvine, where I've been for about 20 years. So anyways, without further ado, I'm going to go ahead and start with this really with some cases. I'm going to present 2 cases, then I'll go in and talk about sort of, how we use it, and then a couple more cases, and then we can have a discussion. So cases are really fun. We'll start with this case. This is a patient with COVID, a 31-year-old female recently, who had cough, fever, and her pulse ox was pretty low. And I'll use some medical jargon, but I'll explain it too as well. But feel free, Chuck, if I say something that you think your audience would need some more explanation, I'm happy to stop and do that too. So anyway, so she was again what we call COVID myocarditis. If you look at these 2 hearts down here, this is taking a portable ultrasound machine and putting it on the chest wall, and you can see this is actually her heart twice. This is right in the beginning of her illness, this image on the right, and this is after she was feeling better a couple weeks in the hospital later. And I don't know if you can see this or not, but this is the left ventricle here, and this is the left atrium, and this is the mitral valve. And if you look at this leaflet here from the mitral valve, it's not really coming up and hitting the septum of the heart the way it is over here after she's better. And what we see with COVID is that it can reduce the ejection fraction, meaning that it can reduce the amount of blood that the heart is able to pump out beat to beat. And just looking at this black area here, black is fluid on ultrasound, and you can see the difference in the chamber size over here. This left ventricle is not nearly as large as it is over here, where this black area really squeezes a lot better. And that's, sort of cardiac ultrasound 101. It's looking at ejection fractions, how well the heart squeezes. This is a very easy window of the heart to get. You plop it right on the chest wall next to the sternum, and the images pop right up on the screen. So it's actually one of the first things I teach my medical students. So this patient actually did better. She she initially was very sick because we're seeing that COVID can cause myocarditis. A lot other respiratory viruses like influenza can also cause myocarditis. We've seen this before, and we're also seeing this with COVID. But we gave her steroids and monoclonal antibody support, even remdesivir, and some high flow nasal cannula. Her oxygen got better. She breathed easier, never got intubated, and was a success story. I'm going to move on now and talk about another case. This is not a COVID case, but this is a nice case to describe how we use ultrasound in those sick patients from sort of soup to nuts, if you will. Right in the beginning, this patient came in, 52-year-old male. He's on blood thinners, and that's an important part of the story. He's on blood thinners, and he's got fever and hypotension. Again, this is not a COVID patient. This is just a very typical patient who comes in the emergency department. He's got a history of congestive heart failure, meaning that his heart doesn't work so good, but now he's got fever and a cough. And so we're wondering, is this a congestive heart failure thing, or is this maybe something like pneumonia? Back and forth, we're going back and forth in our minds about how to treat this patient. And keeping in mind, he's on blood thinners. And so on the physical exam, his heart's beating really fast, his tachycardic, his blood pressure's pretty low, and he's got a fever, and his oxygen level's pretty low, 78%. As you know, that's supposed to be, in the mid 90s or so, and that's definitely hypoxic. And he even tells us, I've got no veins. And so we have to get an IV established right away on him, and it's difficult to do this, especially we know that he's anticoagulated, so we don't want to be poking him too much. He's going to start, bleeding a lot. And so we actually have a medical student working with us out in triage in the front of right when the patients come in off the street, they go into this triage area in front of our ER. And we got a medical student out there working with us, and he performs an ultrasound guided IV. You can see it here, actually. The catheter is going in under ultrasound guidance. So right from the get-go, we're using ultrasound to guide an IV. And in this case, happened to be a medical student, but we have our nurses are all trained in our ER to use ultrasound for IV placement. Patients come in all the time now actually asking for ultrasound guided IVs because they know it's going to be, a little more comfortable, especially in patients who have difficult to access veins. And so the IV goes right in very easily. We get a chest X-ray right off the bat. Of course, they're short of breath, and they've got fever, and the chest X-ray gets read pretty quickly by an attending radiologist as saying pneumonia versus congestive heart failure, and not very helpful to us actually, because we knew that from the get-go. That's kind of what it's going to boil down to, those two diagnoses. But then that same medical student grabs that ultrasound machine and looks at the heart and the lungs. And so here's the heart that the medical student saw. And you've seen a similar heart already. And this is that mitral valve. It's supposed to come up and hit that septum of the heart in this left ventricle. You see it's not doing that. But we knew this patient had a history of congestive heart failure with a low ejection fraction. Indeed, there's not a lot of good chamber size difference here. So again, congestive heart failure is certainly in the differential diagnosis. What we call the differential diagnosis is all the list of things it could be when we're seeing a patient for the first time and trying to figure out what their diagnosis is. And then we move on, or the medical student moves on and looks at the lungs. And this is what pneumonia looks like. I know you may be looking at this for the first time and just seeing a bunch of gray junk on the screen. And that's how ultrasound can be the first few times you look at it. But believe me, it's actually pretty easy to interpret, believe it or not. And I'll get into some of the artificial intelligence, but this is what we call lobar pneumonia. This is a socked-in pneumonia here, and we looked at the left chest, and then the medical student looked at the right chest and actually saw bilobar pneumonia over here too. So this patient actually has bilateral pneumonia, pretty sick patient, obviously. So we get the patient into a bed in the back, and immediately we get the labs back, and they come back pretty elevated. White blood cell count tells us an infection going on, and the serum lactate level that also tells us the patient has this pretty severe infection. We're thinking about sepsis right off the bat. So that emergency medicine resident now. So after medical school, you become a resident. You're still in training, and you're being supervised by your attending. They're together assessing the patient's hemodynamic status, and that's because at this point we have to resuscitate the patient. They have low blood pressure. And however, they do have congestive heart failure, as you saw on that ultrasound. And so we can be very careful how much fluids we give the patient. We have to be gentle with the fluids, but it's also a possible trap. If we under resuscitate or don't give enough fluids, we could actually harm the patient. So in approaching the fluids in a ginger fashion, if you will, we do two things. We use ultrasound to look at the velocity time integral, and that's kind of what they're doing over here. They're using the machine's artificial intelligence actually to find that aortic outflow track, and it's going to measure beat to beat the velocity time integral. It's using calculus to look at the column of blood that's going out the aortic outflow tract from the heart to the rest of the body, beat to beat. It can do that on a beat to beat way. And as the patient's breathing out, if we see these large swings in that cardiac output of that VTI with respirations, we know that we are under resuscitating this patient with fluids, and we need to give them some more fluids. And so we also look at the inferior vena cava. That's how much. That's the big. That's the other side of the heart, where the blood's coming back into the heart from the rest of the body. And if that thing is collapsing down more than 50% as the patient's breathing in and out, we know that we are under resuscitating this patient with fluids. And indeed we were. So we gave, even after 1.5 liters of fluid, we were still seeing a lot of collapsibility here and large swings in the VTI. So we ended up giving this patient more fluids. Now, blood pressure was still low after those fluids. And so now we know we need to put in a central line. This is a very large catheter that goes into the jugular vein. So what you're looking at here is the jugular vein, this large black circle here. And the reason this is a dangerous procedure, if you will, is because it's next door to the carotid artery. You don't want to accidentally stick the carotid when you're going for the IJ, the internal jugular vein. So we use ultrasound guidance there to make this a safer procedure. So our emergency medicine resident, with their faculty supervision, is carefully placing this catheter into the jugular vein. Again, this patient is on blood thinners. And so we really got to be careful about, making sure we do this correctly the first time. And ultrasound prevents complications, as seen by the AHRQ and about 1,000 articles for the past 20 years. And so just with this procedure alone, getting into the IJ. So you can imagine why this is just standard of care now. And so then after we get that line placed, we get the patient on a medication called norepinephrine. It's a way to make the heart beat stronger. And we're repeating the velocity time integral. Patient's up in the ICU. And after a couple of days, the serum lactate returns back to normal. And the VTI isn't swinging around so much, and the patient gets out of the ICU. There's a lot of other stuff that happened with antibiotics and the ventilator and everything, which I won't go into, but suffice it to say, ultrasound took us from triage with a medical student, got the peripheral IV placed, and then helped make the diagnosis by looking at the heart and the lungs, and then helped guide the resuscitation all the way up through the intensive care unit and then out of the hospital. So we use ultrasound here in this longitudinal care pattern. And so how does ultrasound work? Ultrasound's been around for a long time, Basically, it's how the bats find their prey. They send out a pulse and then an echo returns. It's that, and the dolphins do it, pulse, echo, and then submarines do it as well. And they sends out a pulse and echo, and it's basically, the longer it takes that sound to come back, the further away the prey is, if you will, or in diagnostic ultrasound, it's how far down into the body the tissue is. And so the longer it takes to come back, the further down the screen, the device plots a dot on the screen. And the brighter the dot, the more dense the material. It's very simple, very pretty easy to operate. It's been around for a long time, actually. This is Life magazine. Back in 1965, you can see they hooked up this water bath over this woman's belly, and on the oscilloscope, you see the baby's head. And so this was been around. And that's why I think we always think about ultrasound and obstetrics, but again, it's really for the whole body. And so at UC Irvine, we started to think about, how can we use this to get us closer to our patients? How can I use ultrasound? And I was using it a lot early on, and I realized that it does bring me a lot closer to my patient. Because if you look at the way the healthcare system is structured, look how complicated the U.S. healthcare system is. I mean, the patients are over here, and we're way over here as the doctors. We're actually closer to the president in this diagram than we are our own patients. And so it's just mind-boggling how we navigate our way to our patients. And one of the nice things about emergency medicine is that, while this is all going on in the background, I don't have to worry about it too much as an ER doctor. Patients coming off the street, they come right to me. I see them right away, and I can connect with my patient. Of course, I take a history, I perform a physical examination, but what I started to realize right away was that I'm really making a very deep connection by placing probe to patient. And as the images are coming up on the screen, I'm sharing those images with my patients. We're having a nice discussion, and it kind of takes this whole complicated healthcare system out of the picture for that moment. And it's kind of the bliss of practicing medicine, if you will. But it's not just making us have better connections. It's also saving money. And that case that I showed you how we correctly gauged the hemodynamic fluid um, approach to resuscitating our patient in the ICU. A lot of other smart people have been doing this for a while, and they showed that you can actually save about $20,000 a patient by using point of care ultrasound. And we use that term point of care ultrasound. That's the term that we sort of adopted throughout all of the House of Medicine now to describe bedside ultrasound. And so, but like any technology, does this push us away from our patients, especially with our younger learners who are trying to navigate, all of the complexities of being a doctor? Now we're introducing another technology to them. And is this setting the wrong message to our younger doctors and telling them, so actually we took it a different approach, and we said, yeah, this technology isn't going anywhere. And in fact, it makes you a much more accurate doctor by just the physical exam alone. So we said, we're going to teach our young doctors how to use ultrasound right from the beginning of medical school, and how to work it into the patient encounter. Because this was a picture that a child drew. It was published in the Journal of American Medical Association back in 2012. And so this is the problem. Here's the doctor over here. A child, like a 6 or 5-year-old, drew this picture, I think. Here's the doctor over here sitting in a chair on a computer. Here's the patient gurney. Here's the patient. That's the girl who drew the drawing. And this is like her mother and maybe somebody else over here. I'm not sure. But the sad thing about this drawing, and again, it was done by a child without any politics or any kind of ill will, is that the doctor had their back to the patient the entire time. And if that's what the kids are, imagining the care is, then we need to do a better job as doctors and connect with our patients a lot better. And so the other way to examine your patient, or I should say to image your patient, to look below the skin line at what's going on inside the body, of course, is a CT scanner or an MRI scanner for that matter. And it certainly gives us a lot of information. And I use CT a lot in my practice. I'm not saying I don't order CT scans anymore, but I feel like I get as far as I possibly can first with using point of care ultrasound before I turn to using CT. And some people are concerned about the radiation with lots and lots of CT scans. So or in CT scans with younger patients, certainly we tread very lightly with radiation, and we get as far as we can, as low as reasonably achievable in terms of the amount of radiation we're putting into our patients. And so anytime I can avoid the use of the CT scanner and actually have a better connection with my patient using ultrasound, that's what I love so much about it. And you can see some of the devices here. They're very portable. They're wireless. Again, leveraging Moore's law. You can see this one happens to be wireless. It's sending the images right to the cell phone. And we have about over 250 of these portable ultrasound devices now for our medical students at UC Irvine. I have another case here for you. This is a 22-year-old female. This was a patient of mine, and she came in by paramedics. But the stories are always so goofy when the patient comes in to our trauma bays. We're always wondering, like, what's really going on in the field, and this is a good example of that. This woman, again, 22 years old. The only thing we knew, the neighbor kind of knew this person, said, oh yeah, she's got asthma. She gets these asthma attacks. The neighbor saw this woman laying on the ground out in front of her house. And so she called 911, the neighbor did. And when the paramedics got there, the patient was bradycardic, meaning that the heart rate was really low, the blood pressure was really low, and they were turning blue. And by the time they got to the emergency department, they didn't have a pulse anymore. And so they're basically in cardiac arrest, this young 22-year-old female. And we heard this asthma attack, and we thought, okay, so we're doing our primary and secondary survey, and we're listening to the lungs in our primary survey. We don't hear any wheezes. And by now she's intubated, and she's really easy to squeeze the bag when we're intubating. With asthma, sometimes it's really hard to bag these patients. And so we thought, this doesn't seem like asthma. And then a medical student said, hey, they were found outside in front of their house. Maybe they were hit by a car. And so we're like, okay, medical student, sure, maybe they're hit by a car. And so this is the ultrasound we do on patients who are trauma patients. This is And at first you see this, you're not sure what you're looking at. I'll walk you through it here. This is the kidney over here. We're doing the right upper quadrant of the abdomen. And in that area, in the abdomen, blood will pool between this organ right here, the liver, and this organ over here, the kidney. So this black stuff here, this is a stripe of blood here in what we call Morrison's pouch. It's the space between the liver and the kidney. It's the most dependent portion of the abdomen in a supine patient. If somebody's laying on their back, this is where the blood's going to pool, and this is where we look for blood. In trauma patients. And so we're like, oh, yeah, good idea, medical student. You're right. Maybe she was hit by a car. So then we do a secondary survey. I mean, we cut all the clothes off and we examine the patient for any signs of injury. And there's nothing. There's no bruising. There's no contusions, no signs of fractures. And we think, now, wait a minute. Why would this 22-year-old female have blood in her belly, but no signs of trauma? Wait a minute. Maybe she had a tubal pregnancy that ruptured. And indeed, we then look in the pelvis with ultrasound and we see blood actually, we see active bleeding going on inside of her pelvis. And so in a young female of childbearing age, you can get these tubal pregnancies that rupture. We get about 1 or 2 a month, believe it or not, at UCI. And so it's pretty common, this condition of a ruptured tubal pregnancy. So we're always on the lookout for it. And frankly, the ultrasound got us from asthma attack, and then a curious medical student thought about looking for blood in the belly, and then of course that turned into ectopic or tubal pregnancy. And then we talked to our OBGYN colleagues, and of course they know ultrasound really well, and this patient survived. She went to the operating room and survived. And so we had a great outcome early on in my career with this, and that's when we started to really ramp up our training. So this person, anybody know who this is? This is probably the most famous physician of our time in terms of like being the William Osler of medical education. This is Abraham Verghese. And Dr. Abraham Verghese works at Stanford, and he prides himself and his Stanford medical students on doing the Stanford 25. It's the 25 things that Stanford medical students can do with the physical examination. It takes a long time to teach this, and it's difficult to learn, and there's a lot of nuances to it, but it's awesome. It's the art of medicine, and it's a very noble thing to teach. It was published actually in the New York Times. My dean saw this and said, "Hey, Fox, can't we be doing some of this with ultrasound? You know, the UCI 25." And I went through the Stanford 25 and I looked at all the stuff Abraham Verghese was doing, and I'm like, you know what? Yeah, we can. And so we published this article, the UCI 30, and we published it in Academic Medicine a few years ago, and said, yeah, these are the 30 things UCI medical students can do with their ultrasound machines. And so, with the ophthalmoscope on the physical exam, this is Stanford 25 over here, and this is the UCI 30 here. Physical exam and the ophthalmoscope, looking at the retina and the vessels and everything. Yeah, we can use ultrasound actually and not even have to open up the eye. We can put gel on the outside of the eye and the patient keep their eye closed. And here we are diagnosing some cataracts right here in the lens of the eye. And we can look at, lens dislocations, globe ruptures, foreign bodies. We can look at the optic nerve sheath, retinal detachments, all of that with ultrasound. Even we can Dr. Verghese talks about the pupillary response and afferent pupillary defects. This is a physical exam finding. We can actually see those very easily, even under a closed eyelid by using ultrasound. A lot of fun. And Stanford 25, I'm not going to go through the whole thing, but the thyroid exam, palpating the neck. For more precision, we just look directly under the skin. Our medical students look at the thyroid.
Yes, you're doing great for time. So
oh, good.
Don't worry.
Oh, good. Thanks, Chuck, for that update. Yeah, sorry. Sometimes I don't know if I'm
no, this is awesome.
if my internet died, nobody can hear me. I'm just kind of talking to myself or not.
No.
It's tough with the Zoom, But yeah, so the thyroid, looking at the neck veins, you can look on the physical exam subtly at the neck veins, but with ultrasound, we can just see them, And with the lung, tapping, percussing, listening for whispered pectorally or something. We used to have this really subtle thing in the chest on the physical exam. Takes years to perfect these types of things, whereas you can just look and with much more accuracy actually using point of care ultrasound. So an example of that is pulmonary edema. This is a very obvious example here with these lung rockets, we call them, coming to the bottom of the screen here. You put the probe anywhere on the patient's chest and you see these lung rockets, your diagnosis is made in a second. In fact, we're looking at now deploying ultrasound probes to consumer, to lay people, and just having them check their own cells for pulmonary edema and sending the images remotely. as I'll
Wow.
show you here in a minute. Getting back to COVID, it creeps in every conversation. Can't get rid of it. But this is what COVID looks like on ultrasound. Now, again, the first time you see this, you're kind of like, what are we looking at? But this is actually the linear probe with the rib shadow. I'll show you down here. This is a rib shadow right here. That's our landmark, and where the lung itself comes up to the chest wall. Okay, that's what we're looking at right here. So this is normally the lung just slides right along the chest wall. And we don't see any separations there. But with COVID, we see these things called subpleural consolidations. These are these black areas right here. These are these black areas here. We've gotten so good. The entire world has gotten so good with COVID, with ultrasound for COVID now that, I mean, you take, you see this in any setting, and you could be across the room and throw a dart at the screen and say, that's a COVID lung. And
Wow.
the same thing, it's discontinuations in that nice smooth pleural line. We can see these discontinuations here. This is early COVID here, and this is a more advanced COVID subpleural consolidation up here. So again,
Chris,
it's
what component of that is coagulation, microcoagulation, or is this all kind of a more typical pneumonia?
this is a viral type of pneumonia. So it's not any microcoagulation going on here. This is all straight up inflammatory viral pneumonia. And frankly, we started to describe subpleural consolidations on ultrasound 15 years ago, when we had other like H1N1 and other influenza type of pneumonias, with the viral pneumonias that were coming out back then. We were doing this in kids and differentiating. And that's where another way ultrasound's helpful is you could differentiate a viral type of pneumonia from a bacterial pneumonia. Bacterial pneumonia doesn't look anything like this on ultrasound.
Wow.
I showed you a bacterial pneumonia at the beginning of the talk. Actually, there's that big consolidation. We call it hepatitization of the lung. Looks like the liver looks like it's in the chest.
So
But
with
this is what
patient-
viral pneumonia looks like. Very different. These little, the way it puckers away like that from the chest wall, that's a fluid collection here that's puckering away from the chest wall. And that's what the lung is doing. It's pulling back from the chest wall a little bit, and there's a fluid collection that gets left behind in that inflammatory viral pneumonia. Yeah, so back to Stanford 25, we talked about the heart. You roll the patient on their side, and you look at the dime-sized area on the chest wall where the point of maximal input, it's where the apex of the heart comes to the chest wall. You can feel it if you lay over, when you're laying in bed tonight, roll over on your left side and put your finger just, on your left chest there, and you'll feel like your heart kind of beat right there. Well, we stick the probe there. We put the ultrasound probe right on that PMI, point of maximal impulse. And we can look straight up at the heart and see the valves and the flow and the blood. And I mean, you learn so much about not just the physiology and the anatomy of the heart, but also a lot of the pathology and the valvulopathies and things that we can teach our medical students right from the first year of medical school. And then the liver, palpating on the outside of the body, percussing the liver versus just looking at the liver and seeing everything inside of it. Our medical students, if I could brag for a second, we have a program where every year for the past since 2012, they've taken their special powers of ultrasound around the world, and they have taught medical students and physicians in 15 countries now, and gone around and basically done a lot of. I mean, I can't even tell you how proud I am of them and the amount of initiative that they showed. This is all them coming to me and saying, "Hey, Fox, I want to take the ultrasound machine to Transylvania, or to Turkey, Ethiopia." They've gone to all these places, and some places I have connections, with, and I can point. But most of the time, it's a medical student saying, "I have a connection here. I know a doctor here. I know a medical school. They want to learn ultrasound. Can I take some of my medical school classmates, and can we go and use your teaching stuff?" Absolutely, no problem. They go down there and they teach for 6 weeks, and they go back year after year.
Fantastic.
So yeah, it's been really. They've got over 20 publications now of the work that they've done in these countries.
Chris, how many medical students have been taught by them?
So that is, I don't know. That's a great question. Hundreds and thousands actually at this point,
What a
and
great,
not just medical students, but doctors too.
That would be such a great paper.
Yeah, we could tally it all up actually. Yeah, that's a good idea. Good idea. So this is another case here. This is a 57-year-old female, shortness of breath for a month. Okay, I remember this patient in my ER. She was in bed 5, and we got to chatting. She's really interesting. She's a professor at UCI, international expert, and she's on planes like crazy, going around everywhere. She said she was short of breath for a month. The last couple of days, she said it just got kind of worse, and no chest pain. Her right leg's a little swollen, kind of comes and goes, and healthy. No medications, no recent injuries, doesn't smoke cigarettes. Blood pressure was normal. Her vital signs look pretty good. The only thing was that her respiratory rate was over 20, and that's abnormal. So that definitely caught my eye. And her pulse ox says it's okay. Not it's. I wouldn't. That doesn't really really jump out at me at all. Once it gets below 92, I start to look at that a little closer. But 94%, I wouldn't call that hypoxic. Her lungs, physical exam sounded good. Her right leg just had a little bit of edema, a little bit of swelling down there in that right leg, nothing. And so I started to think, maybe she had a blood clot, right? Because she's like flying, and that's a risk factor for a blood clot in this right leg thing. And, once you get a blood clot in your leg, it can actually go to your lungs and cause a blood clot in your lung, a pulmonary embolism. And with this shortness of breath, I'm kind of, that's my leading diagnosis. But we have a blood test called the D dimer. And the D dimer, it is it's a test that when it's normal, when it's less than 500, usually the problem is we get a lot of false positives and we're chasing these clots around for no reason. But when the test is negative, actually, it's a pretty good test. And I thought, well, her D dimer is negative. Yeah, I guess it's probably not a clot then, huh? I'm thinking to myself, get a chest x-ray, doesn't help me. I do an ultrasound of her right groin. And so this is her femoral artery and her femoral vein. Again, black stuff is blood. And this is her, femoral artery, superficial and deep femoral arteries on this side. And this is her femoral vein right here. Okay, common femoral vein, high up in the groin. And this is supposed to collapse. Like this wall of this vein up here is when I push down, what I'm doing right here is I'm pushing down on the probe. It's supposed to push on the back wall here. That's how you rule out a blood clot. You push these walls together. If they don't come together because there's a clot, which is what is sitting right here, then oh, I've got a blood clot. And so indeed, this woman had a blood clot. And I thought, that's weird. Her D dimer was negative. Okay, well, this is clearly a blood clot in her leg. Now I'm worried about her having a blood clot in her lungs. So I look at her heart. I'm looking at her heart here, and here's what I'm seeing. This is the left ventricle, and this is the left atrium. The left side of the heart does the heavy lifting of the heart. The right side is only taking the blood from the rest of the body, and it's kind of pushing out to the lungs, and then it comes back. But the left side is like, again, the workhorse. So the left side is usually a lot bigger than the right side of the heart. When I'm seeing the right side of the heart, the right ventricle, the right atrium get so dilated, it's because it's pushing against an obstruction. Okay, so it's pushing against a blood clot in the lung because the blood's coming from the lower extremities and the abdomen, everywhere else in the upper extremities. It's coming all the way back to the right side of the heart. And then the right side of the heart pushes it out to the lungs. And then from the lungs, it comes back to the left side. And then the left side's pushing out the rest of the body. That's how it works. But when the lungs are clogged with a blood clot, now the right side strains out. So she's got severe IV strain, and this tells me she's probably got a pulmonary embolism now. So, and then this is the short axis, a different view of the heart. And again, the RV is huge, the LV is really small, and we have a D-shaped septum here. This is a massive pulmonary embolism, and somebody who is very mildly short of breath and who has a negative D dimer. It turns out that the D dimer goes up initially when you have a blood clot, but when you have a chronic clot for a month, the D dimer can actually come back down
Oh,
after
wow.
several weeks, which I didn't know that at that point in time. And it almost threw me, that test almost kind of threw me off the scent of the blood clot. But luckily, the history and the ultrasound kept me going on it. So, and that's that's diagnostic medicine. This is how we do it in the emergency department. So anyways, a normal heart looks like this. So again, the right ventricle should be smaller than the left ventricle, but in this woman's heart, you can see how dilated her RV is and her right atrium compared to her left atrium. So this is a normal heart, and this is a pulmonary embolism heart. So it's got us on the right track. Now, there's been a lot of cool innovation out there in ultrasound. There's lots of artificial intelligence. In fact, one of my fellows from 2 years ago, Chanel Fischetti, she's local here to Orange County, and she grew up here and ended up going to medical school at UCI. And as emergency physician, did my fellowship. She's now the chief medical officer at an artificial intelligence company.
Wow.
Yeah, it's really cool. This is a real thing that's coming down the pike here with imaging, where not just in CT, I mean,
All
in
areas of
MRI,
imaging.
but also ultrasound is a lot of good artificial intelligence. And so you can see here, this is the inferior vena cava. That's the person's breathing in and out right here. And as the patient's breathing in and out, um, the artificial intelligence of the ultrasound machine is seeing it collapse, and it's checking the collapsibility index here. It's measuring it, breath to breath. And so as the patient's breathing in and out, the IVC collapses down like that. And that tells us how dehydrated or how much we need to resuscitate them. So really cool. Another thing here with artificial intelligence, you can see these are those B lines, those lung rockets I was telling you about earlier in patients with congestive heart failure. And these are these B lines here. They're counting up the number of lung rockets in the various lung fields. So again, you think about the machines and Moore's law and the technology and now artificial intelligence. I really think this is all going to be consumer grade here in the blink of an eye. Another a way we use artificial intelligence is seen here with the this view of the heart, and this is that velocity time integral. This is the flow of blood, the column of blood that's going down that aortic outflow tract, beat to beat, and actually the machine is measuring it and tracking it as you go along in the patient's care to see how your resuscitation is moving along. It's just a way to keep very close tabs on how you're giving fluids. It's especially important, as I told you, in patients who have congestive heart failure, to not give them too many fluids. Yeah, so a lot of cool AI is coming down the pike. One last case here before I finish up. This was a patient of mine that I almost had a very bad outcome with. This was a 70-year-old male. He had a choking episode at a local restaurant. This is early in my career. I was a fellow in Chicago, and this guy is eating at a restaurant at the south side of Chicago. I'm working at Christ Hospital in Oak Lawn, Illinois, just on the south side there, and it's a really cool patient population. Anyways, I could go on and on about all the cool cases I had that year, but this was a guy who was having a choking episode at a restaurant. A bystander does the Heimlich maneuver. Paramedics get there, and the guy's awake. And the paramedics talk to him, and they say, "Hey, what's going on?" He goes, "I don't know. I feel okay. They just, I have a little bit of pain here in my belly where they did the Heimlich maneuver, but I feel great now. I guess I was choking." And so my resident so I see the guy. He comes in the ER. He's sitting up in the ambulance gurney, and they wheel the guy right by me. And I say hi. He goes, "Hey, doc," like this. And I'm thinking to myself, "Oh, that's somebody. Yeah, I look like I'm probably going to send home pretty soon. The guy looks great." And the paramedic say, "Yeah, he had a choking episode. We brought him in just to be safe." And I thought, "Oh, okay, well, we'll see how he's doing." And then my resident comes up to me like 20 minutes later. "Hey, Dr. Fox, you know that patient who's having that choking episode? I don't know. I'm talking to the patient. The patient says, he was doing okay. And then the last thing he remembers, he's awake. And next thing he knows, he's on the ground and they're doing the Heimlich maneuver." He goes, "Dr. Fox, I think we got to change our algorithm from choking to syncope." Syncope is a medical term for passing out. And I said, "Oh, really? You think this is a syncopal episode, basically a passing out episode?" "Absolutely. And, we need to check the aorta, because I was examining him and he says his belly hurts." He attributed to where the guy squeezed him, but, this could be an abdominal aortic aneurysm. In somebody who passes out and then they have abdominal pain, we worry about abdominal aortic aneurysms. That's where your aorta gets so dilated. It's usually in males over the age of 65 who have a history of high blood pressure. And so, here's this 70-year-old guy who passes out at a local restaurant, and normally he's got high blood pressure. In fact, when we went to go measure his blood pressure, it wasn't high at all. It was pretty low, and here's why: he has a giant aortic aneurysm. Now, the images are. I'm kind of moving the probe really quickly. It's a little bit. I'm a little bit hyper because I'm excited about what I'm seeing here, and it's a really, really old ultrasound machine. But even on that ancient machine, you can tell this big black thing here on the center of the screen. That's what a AAA looks like:
Wow.
abdominal aortic aneurysm. And this one was leaking, and we got him to the operating room, and he survived. But when you rupture your abdominal aortic aneurysm, the mortality rate's very, very, very high. And so to pick these up and before they rupture, and in fact, if you can do an interventional procedure on them, it's a lot. They have a lot faster recovery times than when you're doing a big open crash, aortic aneurysm rupture surgery. So yeah, so with that, I've got two videos I'm going to close with, and one of them is tele ultrasound. And so you can see here, the technology is now available where somebody can be performing an ultrasound at the point of care, and all the companies have this availability now, where you do an ultrasound at the point of care, and the images are being sent live, just like you're doing FaceTime or Zoom calls. It makes sense that the technology is pretty basic to be able to do this now. Of course, with Wi-Fi everywhere, and everybody's getting used to Zoom calls. Now you can just send those images live. So you could have a patient or a junior provider who's learning how to use ultrasound, get those images, a paramedic using them, and send those images remotely, wirelessly to somebody else who can help you, turn the probe. So all of my medical students have this capability on their machines, and they'll be scanning somebody, and all of a sudden my phone will ring, and I accept, and now I'm live. I can see the camera on their phone points to where their probe is on the patient, and then the images are coming live to my phone. And I'm telling them, okay, here's what you got to do. You want to move that probe a little bit more superior and a bit more lateral, and then I want you to rotate it counterclockwise. There you go, right there, just a hair. Boom, there's the image we're looking for there. And yes, I agree with you. That does look like fill in the blank. And so it's a way to do this remotely. Especially, it's been very helpful during, of course, these times of COVID and everything. And we're putting together a cool study right now in Tanzania doing just this. Hopefully this summer when things mellow out with COVID, so the students can actually travel again. So so that's very exciting that that's coming down the pike with ultrasound. And then finally, I just want to show you this is a symposium that we have every year at UC Irvine. It's called UltraFest, and we have a big symposium here for all our medical students and all of the people who can come to us from around the world. Actually, it's free. We get about 300 people come every year. We have about 60 experts in ultrasound come visit us from all over the country and around the world. We have a guest speaker. It starts in the morning, and it's held right here at UC Irvine on the main campus there. And I get a lot of my old fellows come back, and these are the medical students here that run the show. They run the whole show, and it's all volunteers. And we open up the whole medical education building, all 4 floors of it, and we have all these stations everywhere where people can practice ultrasound with all different ultrasound machine equipment, everything. This is a cardiologist here at UCI that everyone loves. This is another faculty here. We're doing musculoskeletal ultrasound. We're doing ultrasound of the entire body. We're doing some procedural guidance. We've got all of our, ultrasound phantoms, and we're playing with the artificial intelligence. We're just kind of just all practicing and working on our skills and interacting and just having a really great fun time. And we're kind of, it becomes sort of almost like a competition to see who can get the images the best, and who the best instructors are. And everyone just shows up, and it's just a super great vibe to share ultrasound with. I mean, undergraduate, college students are coming. We have medical students from other medical schools that don't have a lot of ultrasound yet, and so they're coming out and learning. And faculty are interacting with our students, and our students are really good at ultrasound, so they're really running the show. Here's a pathologist who uses ultrasound in his daily practice. He comes out and volunteers every year. And then at the end of the day, we have Sono Wars. And Sono Wars is a competition that we do. And we have various types of like scanning blindfolded. We have trying to pick out things out of a bathtub, out of a huge bathtub that we put colored ink in. This is Scan Under Fire, where they use this is my son actually shooting me with his with the dart guns, the rubber bullets, and I should say the Nerf guns, and you're trying to get the images while you're getting hit with these Nerf bullets, and it's just silly stuff like that. We have a great time, and we're timing everything, trying to get the images on the screen, and it's just a kind of a really cool way for us all to students to all get together and us to share our love for ultrasound with the folks around us. So that's what we got going on with ultrasound at UC Irvine. A medical student drew this picture of the ultrasound revolution. I told him, I said, I really want like an ultrasound revolution type of picture, because that's really what's happening. We're taking these portable devices and we're using them in a way that is very different than how the traditional form of ultrasound has been used before. And we're just getting it right to the point of care in everybody's hands right around the world. So that's why I wanted that student. He did a good job drawing out these probes in the fist. So I like that one. But yeah, Chuck, I'll stop there and stop for any questions people might have or any comments at all.
Well, Chris, thank you so much. That was just terrific. We have, so one of the questions from Trudy Rhodes is, so how do you differentiate other PNA from COVID on ultrasound?
So, so when you're looking at the COVID lung and you're seeing those subpleural consolidations, that's one of the things with all of imaging. Sometimes you don't have a cinch in the diagnosis. You have another clue, and so in order to differentiate, a viral pneumonia, one viral pneumonia from another type, you're going to have to do a serological test. We actually have a COVID test now at UCI that tests for all the viruses when we do the swab. So we know right away whether it's RSV, influenza A, influenza B, or COVID.
Gotcha.
And interestingly, it's been 0 influenza A, 0 influenza B, 0 RSV, believe it or not, 100% COVID every time we test so far this season.
Great. Chris, another question is, you have alluded to the fact that you see this kind of going consumer, and you can stop sharing if you wish, and I'm going to put some up.
Yeah, no problem.
But you've done some great training and been really exploring how you could help people out, nurse practitioners, primary care doctors, medical students, even consumers, to use ultrasound. Do you want to kind of tell us where you think we're going to be in 5 years?
Yeah, I think I one of the fun things about this career is that I've been able to be friends with all of the manufacturers. So I've traveled around the world. I've been to most of their headquarters, and I've been able to see how they make the machines and nerd out with their engineers. And I mean, some of these people at some of the companies, I mean, some of them are like double PhDs, from Harvard and Yale and MIT, and you're like, a double PhD. I've never heard of that. And they're young. They're in their early 30s, and they're developing. They're just pushing the technology so hard. And so what you're seeing is the best and the brightest minds out there working in these companies that are making the technology with a ton of artificial intelligence, and also also driving down the cost and making it very portable and even wearable. And so as you start to, every time I turn around, I'm hearing about something new where some company, some startup is making an ultrasound machine that a patient slaps on their chest and it just sends continuous, almost like a Holter monitor, but for ultrasound, things like that. And I think you're going to see that type of consumer grade ultrasound permeate its way definitely within 10 years, maybe even sooner, as a lot more care gets pushed to home. We started a thing at UCI. It's called UCI at home with UCI. And it's like hospital at home. COVID kind of forced our hand here, and we're just doing so much more hospital at home, keeping people out of the hospital, but having really good technology to stay connected with them at home. And I think ultrasound's going to play a lot of role there.
Fantastic. And then from the standpoint of, as you look at, we have a patient safety audience. So as we look at a patient safety officer and say, hey, is there an opportunity to expand ultrasound as a way to reduce medical errors? Is there a top 5, top 4, top 3, top 10? What are the things that you are preventing with a robust ultrasound department and using it in the ED? Are there some that just jump off the page for our safety officers?
Absolutely. So for anytime we take a sharp object and put it into somebody's soft tissue, there's a chance to have to hit a blood vessel, to hit a nerve, to hit something that we weren't trying to slice through as we were draining some fluid, or as we were doing a nerve block or putting in a line. So procedural guidance on ultrasound guided procedures across the board. So whether you're talking about central lines or arterial lines or draining an abscess or You know,
Could you,
example that comes to mind is a peritonsillar abscess. Somebody gets an abscess next to a tonsil, pretty common. And, you know, currently, you know, you get a CAT scan for it, and then maybe they go to the operating room. But with ultrasound, we can just put the probe in the back of the throat, see exactly where it is, and guide our needle directly into it. I have a lot of cool examples of that I could show you, where the needle's going directly into the abscess and then pulling out the pus takes a minute and we're done, as opposed to a big complicated procedure where you're just blindly sticking until pus comes out, which is how it's
wow.
usually done, actually. It's a pretty
Yeah.
barbaric procedure.
Exactly. Terrific. That's great. So we'll let people kind of ask additional questions. But since we have a little bit of time and we know that the area that we're really going to focus on for February is what do consumers need to know about these issues? Let me do this. I'm going to just put up what Christopher Peabody and I have worked on, which are the 5 rights of emergency care over the years. Let's just walk around the clock there and help us with what we know now. You know, when we started with COVID, and now this is, you know, although we're kind of like in COVID fatigue right now, but we really are. We're in a kind of a difficult situation. You and I talked ahead of time about these new strains. We're hopeful we're going to peak and then see it go down. But the problem is with these new strains that are popping up, we may be in a sustained environment where we're stressing the healthcare system. Can you just walk us through your advice as we think about the right providers? So I'm going to just ask you some questions and just say, okay, the first right is you've got somebody who's sick. Now they're starting to show the signs of what the CDC says are the trouble signs, the bluish of lips. If they've got a pulse oximeter, they're seeing the numbers drop. Walk us through what we should know about, hey, that's a trigger to go to the emergency department. And then which one should we go to? We have been saying, don't go to urgent care. If you've got somebody who's seriously ill, you better go to the bigger center or where they have the medical records that is more comprehensive. But let's just start and walk around the clock here because we've got a couple minutes.
Sure. So right off the bat, if somebody, you know somebody's COVID and they've been doing okay, but now you're worried that they're starting to decompensate, then if they have any type of altered mental status, they're confused, they're not making, they say a weird word, you're not really sure, what are you talking about? That's your trigger to call 911 right away. So if they have any type of altered mental status, it's not the time to be thinking about getting the person in your car and driving them to the hospital. It's a time to call 911 right away, because you know, when the paramedics get there to your house, that's the fastest way for you to get them some oxygen
Right.
and help control their airways should that be an issue. So, but if they're not all the way to that point yet, and they're just, you know, they're just feeling a lot worse. A lot of people been calling me in the last 9-10 months about, hey, I'm not sure if I should go to the ER or not right now. Let me tell you what's going on. And then for me, it kind of boils down to how many times they're breathing a minute and their pulse ox, what their oxygen is. Because if they're breathing less than 20 times a minute, and if their pulse ox is greater than 93, 92, then I tell them to hold on a minute. Now, if they walk up a flight of stairs and walk back down again, and their pulse ox is dropping below 90%, and that's sustained for a minute or two, and their respiratory rate is in the 20s, then I tell them, you need to go to the ER, because you know it sounds like this is going the wrong direction for you, and we need to start thinking about some therapies. You might be eligible for either steroids or monoclonal antibody. And so that's when I want to get them in the ER. I want to get a chest X-ray. I want to look at ultrasound of their lungs. I want to, you know, check their oxygen level with our equipment, their respiratory rate, their vital signs, and you know, see some of that information. So it's really it's a combination of mental status and, you know, walking up and down stairs, do like a little home stress test. And of all these conversations I'm having, the majority of the time, I tell people actually not to go to the ER. Say, hold on, just stay, you know, call me. Let's do this test again in another 6 hours. Hold tight. Let's see how you do. Because actually, if you came to the ER and your respiratory rate was less than 20 and your pulse ox was greater than 93, we're probably going to send you back home.
Right.
You know, which is, we're happy. You know, that's okay too. But I'm not telling you not to go. But at the same time, you know, those are the triggers for me when I'm talking to my friends.
So when we talk about going to the right provider, and what we'll be talking about it in our next session is if you're taking somebody who is test confirmed COVID positive, or have been exposed, or you have a high index of suspicion, or at all, if you can, we're in California where it's warmer, go with the windows down, make sure they're masked, make sure that you do everything you can to not expose anyone in the car. No need to have the whole family go with grandma or dad or family member. We have a number of close friends now that have lost family members, and the whole family got sick because they took them to the hospital. They were being a supportive family, but they all got in the car. And nothing worse than air circulating in a small container, which is a car, and with no filtration, right? I mean, it's way worse than an airplane. So what we're saying is, do everything in your power not to expose the rest of the family when you go. And then can you walk us through, before you get in to see you, they may have to wait in the car, and the policies vary whether one person can go with them or whether no one could go with them. And now that the emergency rooms are stressed, any tips there?
So if you could take them on a motorcycle that had a sidecar on it, that's probably the best way. I mean, you're absolutely right. Being in a car is, I'd want to have an N95 on if I was going to ride with somebody who's COVID positive inside a car with the windows up. That would be not the.
I just want to make my pitch
yeah.
to those that have kids. I'm amazed at people thinking it's safe to have kids carpool from multiple bubbles when two different families, and they're very careful at home, but then they carpoolers, they can pick up kids because the car is such a dangerous place.
Yeah, I 100% agree. That's how a number of my contacts have gotten, and my friends have gotten it, is just being in a car. And, at that time somebody was pre-symptomatic or asymptomatic, nobody knew, but then everybody in the car got it. This is so common for that to happen. So if you do need to take somebody in a car, windows down, everybody's got masks on. If you got a face shield, wear it, 2 masks, surgical mask, cloth mask. If you have an N95, that's the time to wear it. Absolutely. Yeah.
Fantastic. And then when they go, now we're at the emergency department. We're reminding everybody, make sure to take, if you've got any medical records, take them with you. If you've got them on your phone, so much the better, because that's great to be able to have some recent clinical summary. Bring the medications in a bag, all of them, in your medication list, and make sure you understand what they've taken and when they've taken it. Are these all things that are helpful to you? And then also going to where you've already been cared for before, so there may be prior images and prior chest x-rays.
Yeah, about that. So one of the tricky things with COVID is that, and this is a moving target, and even in my hospital, we've changed our policy a couple of times depending on how bad we're surging. But family members coming back with anybody is not happening anymore, and that's really difficult for us as
Yep.
providers to know what's going on with that patient, especially if they're altered. And I can only imagine the amount of stress that puts on the family member who's like, no, I need to be back there and help translate. They're kind of demented. I know what they're trying to say. All those kind of subtleties there that we're trying to put the pieces together with from our end, is can be really difficult. So, and not having a family member come back with a patient help provide us with the extra history that we need, because many times the diagnosis is found right there in the history. So as much as you can provide a narrative for us, whether it's a written thing or a phone call to the doctor and say, here's what's really going on, that's super helpful. So and if you have like a list of medications, believe me, I mean, we've made a lot of diagnoses just off a medication list. You can kind of reverse engineer what's happening there based on what medication somebody takes, or frankly lack thereof. If they're not on a certain medication, you say, well, it's probably not this other thing. So we're trying to put the puzzle together ourselves as fast as possible. In the ER, we don't know who these, we don't have longitudinal doctor-patient relationships, so we don't know what's going on a lot of times with the patient. Family members, the one that fills in a lot of gaps for us. So just make yourselves available with your cell phone number, and hold tight. We're doing our best to give everybody updates, but it's tough when there's so many patients and we're surging to have that constant communication. I mean, I know what it's like when one of my friends ends up in the hospital. I end up doing a lot of the behind the scenes communication back and forth between
Absolutely.
my friend's family and then the doctors taking care of them. I mean, just on a one-off case like that, you realize, boy, that the amount of communication that we're so used to having by having family members in the room is just not happening anymore. It's very frightening for all parties.
So one of the tips that we give people is now people have a lot more memory on their phones than they used to, and you can actually save a file. And you could save a file in the phone that can be accessible, that can have the clinical resume and a couple, 2 or 3 or 4 pages, PDF pages, and the medication list can actually be in a file on the phone accessible. So that helps enormously to be able to have that and a recent clinical summary, especially with older patients that have had cancer, cardiac disease, on dialysis or whatever, to be able to have a clinical summary resume is been something that you can actually put on the phone, and it's small, but you can take a look at it.
Yeah, I've had a patient's family member text me a file, a PDF like that of like everything that's happened. It's super helpful.
So then right treatment. So what can we anticipate you might do for a family member who did suffer from pulse oximetry? And for those that are not clinical people, this is the oxygen level in the blood. They've probably got severe disease, not mild or disease, but really probably significant disease. Just walk us through maybe the 3 categories of so mild that they probably didn't need to go to see you, those that have mild disease, and those that have severe disease. What would we anticipate as treatment in the emergency department?
Yeah, so mild disease where your oxygen level is normal and you're not breathing that hard and you're actually, you know, you're actually looking pretty good. And maybe we see, if we see 150 patients a day, that's about, 8 to 10 patients or so. Actually, we can, reassure them. And so the treatment is reassurance. Go home, drink plenty of fluids, Tylenol, hunker down and get a pulse ox and do that walking test with the pulse ox. If it drops below 90, come back.
So one flight of stairs up and down. And
Yeah.
then, okay.
Yep. And then the other group where we're like, we're gonna go ahead and treat you here, and because they are hypoxic, their oxygen level is in the below 90, and they're breathing pretty fast. We give them oxygen, and immediately with a little bit of oxygen, 2 liters nasal cannula, in the nose there, just a little bit of oxygen in the nose, it's so low that you can barely perceive that oxygen's going into your nose. And if maybe 4, even up to 4 liters nasal cannula, and if their pulse ox, the finger oxygen level, if that goes up quickly and they look pretty good, but as soon as we take it off, that goes back down again, then we have to make a decision. Is this patient going to be admitted to the hospital for oxygen therapy and monitoring for a couple of days? Are they going to get worse? Or is this person going to be able to go home? And can we arrange for home oxygen for them? So that's what we've been trying to do, just because we've been so impacted with so many patients. There's running out of place to put them. So we've been actually arranging for a lot of home oxygen quite a bit. And so we have our case management working on getting home oxygen arranged for these patients who don't have a lot of other medical problems. So this is your patient who's pretty healthy otherwise, who's going to have probably a pretty good prognosis with COVID. They don't have a history of high blood pressure or diabetes or any other, and all the rest of the labs and the tests that we do look pretty good in the ER. And we don't see like rip roaring COVID lung all over the place on ultrasound. Then we say, this person actually could probably do okay at home with oxygen.
Just oxygen? Would you get them on remdesivir? You do anything more with them, or just oxygen, home oxygen?
So the patients who get remdesivir, and those are usually only the patients we admit. So we're not giving any remdesivir to any patients. Right. That's something that's a judgment call in the ICU. Unfortunately, it's been shown to only be effective in a very narrow subgroup of patients. So all the antivirals aren't really, there's a bunch of other ones like remdesivir that aren't working as well.
They're just shortening the time in ICU and the time in the hospital, right? Isn't that the endpoint that we're seeing?
In certain patients, they are.
Yeah. Okay.
But now there's another subset of patients who, if they're, I don't know the exact criteria, it keeps changing, but if they're a little bit older, maybe over the age of 60, I want to say, and their oxygen level is low, like I think it has to be less than 92%. And they have another comorbidity, what we call a risk factor. Either they're obese or they have high blood pressure. These are the patients that we're going to be giving the monoclonal antibody to. So we have a monoclonal antibody that we give at UCI called bamlanivimab. It's hard to say. We call it Bam Bam. And so we hook them up for and so they can actually get the monoclonal antibody in like an hour, and then we watch them for an hour, and then we send them home. And so if they meet those criteria, if they're a little bit older and they have other risk factors, we give them the monoclonal antibody, and then they get discharged home with or without home oxygen, depending on what their actual oxygen level is. And then finally, if somebody's super sick, and these are the patients we're debating on intubating, so we're doing everything we can to stave off the intubation. We're trying not to put anybody on the breathing machine, because we know that they definitely have worse outcomes then. Where
Prone them.
we prone them, exactly, awake proning. They lay on their stomach and try to stay that way. And we can give high flow nasal cannula. So I talked about that, the home oxygen, the little trickles of oxygen coming in the nose, and that little tiny oxygen tubing, 2 to 4 liters per minute. We can actually give up to 50 liters per minute nasal cannula, high flow nasal cannula, with a lot larger bore
Right.
oxygen tubing. And those are patients that, are in the ICU. And
Right.
so, and these are the patients we're giving steroids to. And it's those ICU players that are eligible that have been shown
So,
to
and the
benefit with the
steroids,
steroids.
if you want to give them, if they're getting the cytokine storm, right? You don't want to give it too early, because that reduces their immunity, does it?
We've seen higher mortality rates in patients that we gave steroids to who weren't that sick.
Yeah.
And so you really want to save it, like you said, the cytokine storm, the really sick ones that,
Yeah.
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 And then of course we're giving the antibody to those patients as well. And then plus or minus remdesivir.
Gotcha. And then one of the areas, as you know, and you've affirmed as well, and Dr. Peabody at UCSF has, is a really big patient safety risk is discharge precautions. So many people are afraid to come back, or they think that they're not supposed to come back, and they don't have clarity in their own mind. Even if you've told them, hey, if you have these things, come back, that's a stressful time. Communication can break down. And many times they don't come back soon enough. We see that at MD Anderson with patients that are cancer patients that hold out and wait to think that the fever may go away. This isn't COVID patients. This is just people that have a low white count, and they wait they always seem to be waiting too long, or wait till in the night, and then they come in because it gets worse. You want to kind of address the importance of discharge precautions as a patient safety issue?
Discharge instructions is something that, we have all these resident trainees, and this is something that the attending physicians are constantly, drilling in the head of the trainee, which is, look, this is where you need to, really slow your roll, really sit down with the patient, sit down, talk to them, look them in the eye, slow the conversation way down, ask them about any questions they have, make sure and get the nurse in the room too. And just see what kind of questions they have, and see where their head is at. Do they understand everything? Do they know when to come back? Make it clear to them, look, if you feel this way, then you need to come back here. It's the biggest risk of all, is when we send a patient back out into the wild. And if we get the sense that they are not reliable, or that they are not understanding what we're saying, then we're going to keep them a little longer. We have these observation protocols. I got 20 observation beds. I can keep somebody for 24, 48 hours if I have to in my ED to see, sometimes it's just a tincture of time that we
Right.
need a little bit more time for whatever they have to either declare itself and get worse, or to get better. And, a little more monitoring helps. But if we have somebody who's super reliable, and they live at home with a nurse, and the nurse is like talking to me on the phone, and I'm like, all right, I feel good about this discharge, you're out of here, versus, somebody where we have a significant language barrier. I'm using the interpreter machine the whole time, and it's like they can't really hear me very well. I'm like, or this person's not understanding me. I don't really get a sense that they're understanding this, or I don't really, this doesn't feel right. Let's put them in observation, keep an eye on them for another 6 hours, and then we'll recheck their labs and imaging and see kind of where they're at. Tincture of time. That's the thing with emergency medicine. we have these episodic doctor-patient relationships. It's like two ships crossing in the night,
Right.
and we're doing everything we can to try to connect with them and so that and build that trust. And it's an art form, really. But in the end, ultimately, we can't admit everybody, and we have to make a decision, or our nurses will kill us. So, but yeah, so we definitely try to have that communication there. Key.
And I can just attest to the fact my son, when he was little, split his the skin open just lateral to what are the orbits. We had a plastic surgeon sew it up, and we were just, you're so traumatized when it's a child. And here I'm a patient safety guy and really understand this. And both my wife and I failed to get the discharge antibiotic and he got a little bit more of a scar because he got an infection. And it's stressful. All of us, I don't care how smart you are, if it's a stressful event and it's your own loved one, don't count on remembering anything. Like, write it down, make a list, double check it. So important. And then finally, the importance of follow-up and continuity of care with the primary care or the attending physicians for active medical problems. In this world of COVID, so many breaks now of people not being able to come in. They might not learn how to use telemedicine. They're not sure they're supposed to go back to their attending physician, and they've got active medical problems that are separate from COVID. Anything you want to kind of help us with there?
Yeah, this is the real crux of it. This is like the handoff. If we can ensure that patients have a primary care doctor and they know that doctor, and they're like, I'm going to call Dr. So-and-so when I get home. We love hearing that. That's like music to our ears. And that means that someone's got, another set of eyes to look at the whole situation and to follow up with them. So, and there's a lot more, even if it's a video call, even if it's like, hey, my doctor, I have a video call set up for tomorrow. They're gonna check in on me, and I'm gonna show them. My husband just went and bought the pulse ox, so I'm gonna put that on when I get home. And we're like, okay, that's awesome. Thank you for following up. But we have case managers in our emergency department who, a lot of our patients don't have any primary care doctors. They have insurance, but they've just never made that appointment. They've never gotten in.
Right.
And we can definitely get them in our system and get them hooked up for same week, second day follow up kind of thing, and or hospital home at home with UCI. We can hook them up with that as well. And if they have no insurance, we actually have a mechanism for getting them one follow up visit in our system that we have around the hospital. So, but yeah, the follow up part is really, really, really critical, as you said, Chuck.
So we've got a question that came in on oxygen. How hard is it to set up oxygen at home? And then is the family trained about the precautions and the safety regarding oxygen and managing that? Tell us about that, because that's kind of a question that's popped up multiple times here.
Yeah, it's a cool question. It's actually not that hard to set up oxygen at home, believe it or not. They have these oxygen for low flow oxygen. So like for 2 to 4 liters per minute, they have these oxygen concentrators that the patients use that we set them it's like we call durable medical equipment. We put an order in for it, and then this in our computer, the ER doctor puts the order in for a durable medical equipment oxygen concentrator, and then the case management person sets it up, calls the company, and arranges for the patient to get it that way. And yeah, you don't want to be smoking a cigar around the oxygen concentrator. But that being said, these aren't like the cylinders where you could turn it up to 25 liters per minute and it comes flying out. And this is pretty low level oxygen, but it's just enough to kind of keep the patient.
What's the flow?
comfortable
What's
enough.
the max flow?
I think it's a 4. I'm not 100% sure, but if I had somebody who had an oxygen requirement greater than 4 liters per minute, I'm not going to send that patient home.
Yeah, got
Someone
it.
else might, maybe an inpatient doctor, a hospitalist might, but not an ER doctor.
So final question, and then we'll go to Arlene and give her an opportunity to ask any questions, and then she'll close. But just while we've been on, and I know you're a surfer, and my son is a surfer, and I just was notified on my phone that where he surfs, which is Lowers nearby here, somebody just had to be resuscitated or passed away. And that just brings to the issue of, we got COVID in the background. Any tips do you have if you've got to be a good Samaritan and help someone else? We're saying, look, if you got to be a good Samaritan and you carry an extra mask with you, and you carry our care kit, our care packs that we recommend people have in their car with the tourniquets and extra mask and extra gloves, is if you put a mask on somebody that you're helping and you've got a mask, you're pretty safe. You would not deny trying to help be a good Samaritan, would you? What's your tips there? So my son Charlie's down surfing at Lowers and somebody has a problem. We're teaching our kids how to do two-man CPR with a bag valve mask. They're getting the BLS training. And those kinds of precautions can really protect us as good Samaritans, can't we, as when we're out there trying to help others be a good Samaritan?
Yeah, I love the spirit of that, Chuck. Absolutely. And of course, let the paramedics get in and do their job, and get that call out right away. And you're waiting for the
911
paramedics
right
to
away,
arrive.
please. Yeah.
As you're waiting for them to arrive, of course, we're, if you have a bag valve mask like that, that's great. But just keep in mind, as you're trying to arrange the mask on the face, that silastic material or whatever, it's kind of trying to get in there. It's covering up, but you could squeeze the bag, and then you could actually aerosolize a little bit of some of the secretions. And so I'd be looking for my N95 in that situation personally, and a face shield. And I think we always talk a lot about rescue or safety coming first. And so that's, the kind of thing I would definitely, certainly compressions, no problem at all. Have a regular mask on for compressions. But if I was bagging somebody in the field, I'd have to think about this a little bit more. I haven't really thought about this until you just asked me, but just my own sort of nature. If I was BVMing, bag valve masking somebody in the field, and squeezing that bag, and if there was a little bit of a secretion, it could aerosolize. Although you're outside, and especially if it was windy, it would be fine. In some ways.
In our rescue kits that we're putting at multiple coves, we're putting face shields, multiple N95s, gloves, and that kind of thing to try to help them. And a lot of times it's kids that you're resuscitating that have gotten out too deep, or more athletic people that are here. Well, listen, Chris, thank you so much. You've just been terrific. Arlene, I would like to ask you to comment on what you've heard to Fox today. Any comments or questions that you have for him? And then if you'd like to close us, that would be wonderful.
Okay, thank you, Chuck. I just want to say thank you, Dr. Fox. That was really interesting. I'm not a medical, I don't have a medical background or anything. And it was kind of eye-opening to see ultrasounds and to have you explain it. You must be a wonderful teacher because I understood what you were saying. I've never seen it, but that was really interesting. And that point of care ultrasound, it sounds like it's just a whole new world for patient safety. Be poking somebody all the time now, you don't have to do it. And if patients who are like that need that at home, I can't wait. I mean, to just imagine that you have that equipment at home if you're one of those ill patients that would need that kind of thing. And that's just like the pulse ox, how we could all get them at home now. I think that's wonderful. I didn't know that. So thank you very much. Thank you for your presentation. And I want to thank everybody out there too for being here today. I know we're all busy and we got a lot of things going on, especially those in medicine. And I appreciate taking out the time to learn something, maybe quite a few things. And thank you, Chuck. Back to you.
Wonderful. Well, Chris, terrific. And we look forward to perhaps getting a little more insight for you as we think about the skills that our families need to have if the healthcare system gets overtaxed. Even we know here in California that we've had some 911 crashes, and we know that we've had emergency departments that are just so full that it's just hard to get anybody in, that we all need to learn how to safely get our loved one to you, and what the skills are that we need to do. So we're going to focus on that for the first week of February. So thank you for your world-class contribution and all we're doing. So thank you so much. It's what a great presentation. And the other thing is I'm so excited. I'd love to take the course with the medical students. You just got me jazzed. So.
Yeah, they have a lot of fun. We have a lot of fun with Ultrasound. Maybe for Ultrafest, once we can all be together again, you come by and check it out.
Count me in, man.
Yeah.
I'd love to go. I'll be a dummy. They can do it on me. Well, listen, thank you, and God bless to everybody. And we keep safe and maintain. The other thing we'll leave with you is it looks like we're starting to get recommendations to move from cloth masks to surgical grade or medical grade masks because of the transmissibility. So we want to leave that with all of you. Aerosol critical, poorly ventilated areas more important. The last number, which is a sad number, is with 50% more transmissibility, we have 11.4 times more deaths. So just because it's 50% more transmissible and it's equally lethal, that doesn't mean that it's equal number of deaths. It means it's 11 times the deaths, which is just staggering. So thanks for all you do, Chris. God bless everybody.
Thanks for having me. Take care.